We are honored today to have Datuk Seri Dr. Doshi as our chairperson and Dr. Vijayan as our speaker today. The topic of today is lung ultrasound in COVID-19. Datuk Seri Dr. Doshi is a AIM consultant in Hospital Ganga and also the head of Department of Medical in Hospital Ganga. So I'm very sure today we will learn a lot from today's session. As lung ultrasound in COVID-19 is a new thing right now. We should learn this technique and we can practice this technique in our daily practice. So Dr. Seri, Dr. Paras, the floor is yours.
Thank you very much, Dr. Ang, for the wonderful introduction. Just like to clarify, I'm not the head of department. I just head the acute medicine unit here at HTF. It's great to see you all on a Thursday afternoon. Thank you for making the time to see us today. COVID-19 has taught us a lot when it comes to thinking out of the box. And ultrasound has been a very, very important tool for physicians, for us at the bedside, in picking up COVID-19, especially when CT scan facilities are limited. It saves the trouble of having to move the patients from the ward to the CT scanner, and it also gives us a diagnosis almost instantaneously. For this today, we have a very good hands-on ultrasound come physician, come AAIM, all rolled into one. With us today, we have Dr. Vijayan and Laki Panirselvam. Now, Dr. Vijayan actually is an AAIM consultant in Klang Hospital. Now, when someone is practicing in Klang Hospital, obviously we need to know their background, because no people who are mentally well will go to Klang unless they are forced to. All right, we all know that it is a hotbed of cases and it's extremely high patient load. Dr. Vijayan actually graduated from Premier State University and he did his master's in medicine in University Malaya. After completing his Masters of Medicine, he then did AAIM, which is Advanced Acute Internal Medicine, and has been posted to Klang Hospital. His areas of interest include ultrasound at the bedside. He loves doing OGDS and colonoscopies as well. And by virtue of being in Klang, he also has extensive experience and enjoys dealing with dengue patients, which I'm sure not all of us do, but he enjoys dealing with the dengues, the severe dengues, all right? And of course, along with ultrasound, and now he has been experienced in dealing with COVID as well. Without much further ado, I would like to hand over the floor to Dr. Vijayan. Thank you very much for being with us here today.
Okay. Thanks, Datuk. Thanks, and good evening to everyone. Let me share my screen first. Okay. So hope all of you can view my screen clearly. So today, my topic will be ultrasound in COVID-19 pandemic, viral pneumonia, lung and cardiac. So most of my presentation, about 90%, is going to be lung ultrasound. And I have included about few slides on cardiac and IBC at the end of my presentation. The reason I added on this cardiac and IBC is because one of our challenges when we scan viral pneumonia patients will be, what we seeing a B line, is it showing us a cardiogenic pulmonary edema, or is it purely viral pneumonia? So this cardiac and IBC may help us to establish a concrete diagnosis. So let's move on. This will be my outline of presentation today. Part one, I will touch a little bit on basics of lung ultrasound. Most of us maybe already had our basic trainings on ultrasound. Maybe few of us on this webinar today may not had a proper training or basic training of ultrasound. So I will touch 2-3 slides explaining on basic principles of lung ultrasound. Then we will move on to a more detailed discussion on ultrasound in viral pneumonia, COVID-19. Then I'll touch a bit on echo and IVC as I promised earlier, a case discussion. Then I'll wrap up with my pitfalls and limitation in ultrasound. What the outcome of today's presentation, what's my aim is that all of you can distinguish between the finding of COVID-19 pneumonia, a viral pneumonia, and you can differentiate between cardiogenic pulmonary edema or bacterial pneumonia. So we move on to our first part, the basic on focus. We talk about equipment. I think we should start with the ultrasound equipment and how we are going to clean it. The cleaning part means is infection control. Then I'll talk a little bit on this A line, consolidation, the B line. So if you see, the scan that I'm using is a portable ultrasound, it's a Lumify. So when I'm going in to scan a patient, I'm only bringing this scan, this pot with a wire, and it's a multi-purpose probe where I can use it for lung, cardiac, and abdomen scan. And this probe will be attached to a phone or tab as you need it. You doesn't need to push in a big machine inside and outside to scan. And I will use Sani cloth. This has been proven to be used and benefit for COVID-19 virus. And the wait time, that means you need to clean it pre and post scan. And the wait time is 2 minutes. That means once you clean, you have to wait for 2 minutes to bring it out the probe. Okay. And if you see down here, there's a packet. This is called a lubricant gel. I usually prefer to bring this packet, few of it with me. Once I use it, I discard it inside the yellow bin. If you don't have this, you can use a syringe, fill it with your gel, bring it in, use it, and you just throw it away the syringe. So the only one equipment that will be going into the room and coming out will be this probe, which will be cleaned properly, pre and post scan. So with this, we can make sure that the infection control be taken care well. Now we will move on to the examination point. If you check out in the literature, there are quite a number of methods, scanning points for lung. The reason I'm using these 12 examination points is few reasons. One is easier to approach, easy to remember. And most of our COVID-19 ultrasound sound guidelines or papers are based on this 12 points ultrasound examination. It's quite easy to remember, where you divide patient to the left and right. Left, you scan zone 1, zone 2, the upper and lower, anteriorly, then laterally up, down, and you go to the posterior, upper and lower. So 6 points on the left, and you can repeat the same thing on the right side, 6 points. So you get 12 points examination. Later on, in the presentation, I will emphasize again these 12 points when my presentation goes to scoring system. And most of the time, our patient will be in a prone position, and patient might be obese, patient might be on modified CPAP and in a prone position. So how are we going to scan if a patient in a prone position? So this paper have shown we use swimmer position in prone position. So if you're going to scan on the right side or left side of the patient, you just need to abduct patient's arm, place a pillow underneath the shoulder, and you can try to scan the lateral and the anterior part of the lung. With this method, you may be able to get all the 12 points for this patient. Now, we have covered some basics of equipments and scanning points. We talk about the bad sign. When we're doing lung ultrasound, they're going to have about 10 signs to look for, but I'm not going to discuss all these 10 points because our aim here is not a basic ultrasound, but we are going to look at the advanced ultrasound in COVID-19. But I'm going to just cover this one sign, which is very important, because you need to get this bad sign accurately so that you can use the imaging and to make a good and proper conclusion about your scan quality. So bad sign is when you place a probe, this is the skin. So the probe is placed there, and this image shows your rib. And you can see below the rib, This is the shadow, the dark shadow. And the first structure that you need to identify is the pleural line. And the following structure will be the A line. So this is what we call as a bat sign. It just resembles like a shadow of a bat, the wing and the body. Now let's look at this A line. Most of my scan videos going to be looking at the B lines. So I want to emphasize first what is A line before we move on to our B line. So what is this A line? What does it give? What is the implication of this A line? So whenever we scan a patient here, we put our probe here. As I told you, the first structure that we're going to notice is your pleural line. So the A line is just a reflection of your pleural line. What happened is the echo touches the pleural line, it reflects us back, and it goes down, it reflects us back. So it's just a reflection of your A line, pleural line, which shows your A line that resemble that the lung is normal. The lung is just a hollow organ, doesn't have any consolidation or pleural effusion. So now another sign that we want to look at it is a sliding sign. So here you can see clearly the parietal and visceral pleura is sliding on patient's inspiration and expiration. Okay, so the first part is over. I just covered some basic on scan, looking at bat wing and the A line. So now we are going to go into a detailed discussion on COVID-19 patients. Before I further do to continue with scan pictures and videos, let me look at the evidence, because ultrasound in COVID-19 has been something new and something new that we all practice. So we need to look for evidence that support that what are we looking at is correct and support us to further on our examination of the patient. So this is a very old paper which was published about 10 or 15 years ago. Last time, ultrasound was not used to scan lung. It was always believed that ultrasound is not suitable for lung. But about 10 years ago, there's a conference done and they came up with a recommendation that ultrasound is highly accurate to detect pulmonary edema, APO. It can be used to also pick up ARDS, fibrosis, consolidation, pleural effusion, and even viral pneumonia. This was done about 10 years ago. And this committee actually went through about 300 of papers, case reports, case series, books, and they went through about 300 papers and they come up with a lot of recommendation which suggests lung ultrasound is highly accurate to detect lung pathologies. So now let's move on to COVID-19 pneumonia. This paper, which is was published from China, their intensive care unit, was one of the first paper which I went through before I start scanning patients. So they took about 30 or 38 patients and they actually compared the findings between the CT and the lung ultrasound. And their main objective was, can a lung ultrasound pick up the lung pathology which is seen in CT? So we go through one by one. In CT scan, when they see a thickened pleura, you can pick up these abnormalities in ultrasound. B lines. Whenever patient have ground glass appearance or pulmonary infiltration, you can look for B lines or confluent B lines. Later on, I will explain what is just a B line means and what is confluent B lines. And we know that subpleural consolidation, which is another significant findings in COVID-19, also can be seen in an ultrasound. Pleural effusion is a very rare, which also easily can be picked up, and multilobular distribution abnormality in COVID-19 can be also picked up in ultrasound. So this paper have shown that the lung ultrasound is sensitive or equally sensitive with CT scan. And this is another case report. It's from France, where this is about 58-year-old gentleman admitted with category 5 to their ICU. So what they did was they CT scanned him, and immediately they did an ultrasound, and they compared the findings just to prove is it accurate. So we go step by step here. This is anterior. So you see in the CT scan, the anterior was normal. And in ultrasound, you can see A line. That shows it's a normal finding. So when they move to medial, where you can see a lot of ground glass appearance happening, and in ultrasound, you can see B line, which is almost accurately showing the CT scan finding. And when they go posteriorly, where you can see a subpleural consolidation, and in a lung ultrasound, you can see the sign of subpleural consolidation being picked up. So this paper have shown clearly that ultrasound lung is sensitive to pick up the changes in the lung as good as CT scan. Now, what are the findings that we are going to look for when we are going to scan COVID-19 patients? Thickened or irregular pleura, as I mentioned earlier, B line, subpleural consolidation. These three will be the most common finding in COVID-19 patient. Sometimes we do see consolidation and pleural effusion. I think pleural effusion will be very rare. It accounts about 2-3% of most of the COVID patients. So let's look at this B line, which I've been talking earlier. I think earlier I've explained about A line. So now we jump into B line. B line does not mean viral pneumonia. B line can resemble viral pneumonia, pulmonary edema, ARDS, pulmonary fibrosis. So there are a lot of differential diagnoses when we see B lines. And to say this B line is significant, is pathological, means there are few criteria you need to fulfill. That this B line rises from the pleura and goes all the way down. If it stops halfway, or it starts from here and stop here, this is called Z line. So this is not significant. So whenever you say a B line, you must make sure it arises from the pleura and goes all the way down. And you must have at least 3 B lines seen to say this is significantly a viral pneumonia or is significantly pulmonary edema. So that's the criteria that we have to confirm that this is a B line. So just to recap back, this is A line, which is normal lung, and this is B line, which you can have a viral pneumonia, pulmonary edema, or lung fibrosis. So now I'm going to play 2 videos side by side. This will be a normal lung, and this will be a viral pneumonia lung. And so here you're going to see a A line, and here you're going to see a B line. So let me play the video first. So hope you can differentiate the A line and the B line. Okay, so we have talked about B line. Now let's move on to subpleural consolidation. So how are we going to look for it? How to pick up the subpleural consolidation in lung ultrasound? First, just to recap, if you notice, this is our normal pleural line, a straight thin line. But when you look at it here, you can see the line is a bit thickened, and at the halfway, you can see the line is broken. So the structure is broken. So this area, which is called subpleural consolidation, which frequently seen in COVID-19 pneumonia, or mostly in a viral pneumonia. So another example, you can see this is a pleural line, and you can see it's become a bit irregular here, and it start to break. It lose the shape. So this is a subpleural consolidation. Here, this is another picture of lung consolidation, or we call it as a tissue paper sign. where you can see a lot of white spots. This white spots shows the air bronchogram. It's more towards bacterial pneumonia. Okay. So there's a video of subpleural consolidation. So try to focus on the right side of the scan here, where you can see the pleura is irregular here, and you can see it's the break of the pleural line here, which shows a subpleural consolidation. Okay, so now I'm going to share some real scenario patients from my hospital. So this is a 56 years old female, COVID-19 category 4, day 8 of illness. So for this patient, I'm scanning her right lung, and I'll be dragging the probe from upper lung, upper lobe, to the left, to the lower lobe. So you can see in the upper lobe, you can see a lot of A lines. So when I drag the probe down, you can see appearance of B lines. So now you can see a lot of A line. And when I drag to a lower lobe, you can see a very confluent B lines. So now this is another patient, and his finding is the other way around, where the B line is more prominent on the upper lobe, and the A line is at the lower lobe. So this is the upper lobe, right? This is the lower lobe. So I'll play this video again, where you can even see a curtain sign. This is the upper lobe, B lines. When I move my probe, I overshoot a bit down there. I'm looking at the lever, go up a bit here. And you can see a curtain sign with the A line here. The reason I put up these two scans here, just to show or to explain that in a COVID-19 pneumonia, it can be very localized, where a pathology can only lies in one lobe, in a single lobe, where the other lobe can be normal. That's why we always emphasize to scan all the 12 points, where we scan upper and lower, anterior, medial, and posterior to pick up the B line. And now this is another patient who have a subpleural consolidation. So you look at it, when I drag the probe down, the subpleural consolidation will appear over this area. So you can see the pleura is already thickened, a bit abnormal, and you can see here irregular, and here you can see the break. I'll just replay again. Yep, you can see here, there's a break in the line. And this is the subpleural consolidation, which is very significant for viral pneumonia. So now, just to recap, we have seen B lines, we have seen a subpleural consolidation, and we also know it can appear in a single lobe, multiple lobe, upper lobe, lower lobe. Okay. So now I'm going to move forward with another finding in COVID-19 pneumonia, a very significant finding in COVID-19 pneumonia. Before going to this paper, earlier when I started to scan, I came across a patient which had both A line and a B line at the same setting, at the same view. Initially, I thought I might had a wrong techniques. So when I checked for literature, and I came across with this literature from Italy saying that very specific finding in COVID-19 where a B line can be seen at the background of A line, which is called light beam. So why this happened? Why we have this light beam? Where initially, before COVID-19, we were taught that you will only see either A or B. A normal is A, when patient has pathology is B. It was told that when COVID-19 pneumonia starts ground glass appearance, their alveoli, which goes into infiltration, and their alveoli is preserved and normal in the same lobe. So this gives us a picture of A line and B line together, which is very significant for COVID-19 pneumonia, and it appears at the early stage of ground glass appearance. So I will show you, actually in this paper, the author have published about 5 or 6 videos of his patients which had a light beam. So I will show about 2 videos. So here you can see a A line. At the same time, you also can see a B line. This is also category 4, day 6 of illness. So here I'll be showing another patient also had a light beam, category 4. But the special scan, the special thing in this scan is the lower lobe shows light beam where you can see both A line and B line. And when I drag the probe upper lobe, you can see a confluent full-blown B lines. So here you're seeing a light beam where A and B. So when I push it to the right upper lobe, you can see a very confluent B lines. That means multiple B lines. So this shows that in a COVID-19 patient, the lobes, the multiple lung lobes are at a different stage of COVID-19. So the lower lobe is at the beginning stage of ground glass appearance, which has a light beam, and the upper lobe scores more advanced ground glass appearance, where we can see a confluent B line. So it doesn't happen spontaneously, all the lobes happening at the same time, but different lobes has a different stages of ground glass appearance, which can be picked up in ultrasound. So now we have seen scan, B line, subpleural consolidation, light beam, and all these pathology in COVID-19 pneumonia. So what can we do with this information? Can we score them? And why do we need to score them? If you see doing an echo for heart, we do score them by doing a proper measurements like EF 20 or 30%, by doing a LV measurements. So these measurements are very objective, very concrete, and we can carry forward it to follow up a patient. So can we score lung ultrasound? Yes, we can. Later, the next slide, I'll show you how to score. So this paper have done a scoring. It's done in Brazil. They have looked at about 180 patients, and they have done a scoring system using 12 points. And they found if the score is high, for example, 26 points, it's very significant, showing a higher mortality rate, or this patient require intubation or ICU admission. But those who have a very low score, less than 25, have a better outcome. So this paper have shown that scoring system can be used for prognosis prediction. And there are quite multiple papers being published after that to show that scoring system is also another sensitive method to predict clinical outcome. So this is one of a scoring, a very easy, simple scoring system been used in Sydney Hospital. So they are using back these 12 points. Again, you can see the R1, R2, R3, R4, R5, R6. So just they name it all the 6 points as a R1 to 6, and the left side L1 to L6. So how are you going to score them? If you put 0, if you see a normal lung, or less than 3 B lines. 1 point if you see more than 3 and more B lines. 0.2 if you see a confluent B lines, that means you can't count these B lines, there are multiple B lines. And you give 0.3 if you see a subpleural consolidation. So with that score, you can just fill in the blanks, 1, 2, 0, 3, then you can sum up how many points do you get. So what's the advantage by doing this? When we do a scan, like for example, echo, we do a documentation. We have an echo report, which we can refer to it again after admission, on discharge. We can use it to refer to a cardiac center. But when we do lung, we should also have a proper documentation where we can carry forward it. It can be retrieved back to look what happened on patients 20 or 48 hours ago. Then we can rescan him and see, does this patient responding to treatment? Or this patient is getting worse by counting this point system. And this scan might be done by someone else from ED. So if they have done a proper documentation, you can look back to their documentation and you can rescan and compare the findings. So I will suggest, if you are doing a scan, to have a proper documentation such like 12-point zones with this point system, where you can retrieve back and we can compare with your previous and the current repeated scan outcomes. So as I promised earlier, I will touch a little bit on echo and IBC scan in COVID patients. Before I jump to echo and IBC, does anyone have any questions, or does anyone want to look back into the scan pictures again, just to repeat one or twice before we go into echo and IBC?
So I believe there's one question posted, Dr. Vijayan. Is there any post-COVID significant investigation along doctor encounter? I'm not exactly sure as to the idea. I mean, can the attendee clarify that question? In the mean, so then Dr. Vijayan, we can look at it again after this section. No questions for now, Dr. Vijayan. Nothing posted yet in the Q&A. I believe we can proceed.
Okay, so we have done with this lung ultrasound. Now we will look into echo and IBC. Echo itself is another huge topic, and IBC is another huge topic, but I've cramped it into 2-3 slides, where in echo, I'm only going to look into a parasternal long axis view. That's all. We are not going to discuss what other views. Okay. Why? Our aim is just to look at LV function. How good is the heart contracting? And with this parasternal view, we can make some eyeball rolling judgment looking at the patient's LV function. So I think most of you may have already some basics on echo, which you may be able to appreciate. But if you are not, so when you do a parasternal view, this will be a standard view that you will be looking at your monitor, where our main focus will be on the LV. So I'm not going to talk about our pericardium, LV, descending aorta, or RVOT. So how are we going to make an eyeball rolling judgment on LV function? If you are someone, MA, who've been doing scanning for the last 10-15 years, yeah, you can just look at it and you can make a judgment call. But if you are someone new, you have to look at few anatomical structures to decide what is the LV function likely to be. So there are 3 things that you can look into. That you look at the anterior leaflets of your mitral valve. If this mitral valve can flip and touch the IVS wall, that's called a E point, then the EF is good. Then you look at the thickening of both IVS and infralateral wall, and you look at the space. When it's contract, it should be contracting at least about 50% of the space. With that, you can conclude this patient has a normal EF function. Now, IVC. So I think most of you might be good in doing IVC scan. So whenever you scan, you're going to look at 3 structures: the RA, liver, and your IVC. So when you look at your IVC, you're going to freeze the diagram, and you're going to do a simple measurement. Or you can do it a bit more advanced, where you can put it at M mode, freeze it, then you can take 2 measurements on expiration and on inspiration. With these 2 measurements, you can do a collapsibility index, or we call it as a Cavell index, where the expiration minus inspiration, and you change it to percentage. So why we do that? By doing that, you can make a rough estimation the patient's volume status. So if you have an IVC which is less than 1.5 cm and is collapsing, usually you know this patient is under volume. If somebody in between about 1.5 to 2.5, collapsibility is less than 50, you know it's euvolemic. And someone with more than 2.4 or 2.5 and it's not collapsing at all, you know this patient is overloaded. So with this information, you can make a decision, this patient is overloaded or under volume. And the B line you're seeing, it might be a viral pneumonia or is it pulmonary edema. So what I'm going to do now is, I'm going to discuss a case scenario. The reason I choose this case is the management and the diagnosis of this patient was changed after the scan, after my scan. So let me see. This is a 36 years old lady. Para 1, last childbirth was about 2 months ago. Came in with our ILI symptoms for 6 days. Shortness, but this patient also complained of shortness of breath for 4 weeks. On clinical examination, this patient has all the failure symptoms. Pedal edema, JVP was raised. There's some inspiratory crackles. PCR was positive, CT value was lower. And patient required about 10-liter face mask oxygen. Further history, patient had a failure symptoms like when she was pregnant, 3rd trimester, and patient was given an appointment for echo and MOPD, but defaulted because of the COVID pandemic. So at that current, patient was diagnosed with COVID-19 pneumonia, category 4, day 7 of illness. Patient was started on steroid and baricitinib. And I went in to proceed with the ultrasound, bedside lung and echo scan. So I did a simple measurement. I scanned, I saw a B line. And if you see, the R1 and L1 showing the upper lobe, which is 0, it was quite clear. But more findings were at the middle and lower zone, 2, 2. So it is very symmetrical distribution and more prominent at the lower lobes. So I proceed with echo. So at one look, you know that this EF is very poor. You can see the mitral does not flip. The contraction is very poor. Look, the LV is dilated. So eyeball rolling, I can make a call that this patient has a very poor LV function. Maybe the EF is about 20%. And this is an IBC scan of her. And you can see the IBC is dilated 2.4. And when I calculated the Cowell index is only 12%, that means it's not collapsing at all. With that, we changed the diagnosis as an acute pulmonary edema, most likely secondary to postpartum cardiomyopathy, and COVID-19 category 4. We started her on intravenous diuretics and with fluid restriction. Within about 24 hours, we managed actually off oxygen. When I repeated the scan, the score reduced to 8. Initially, the score was 16, reduced to 8. So we actually downgrade her diagnosis COVID-19 category 3, day 8 of illness with underlying acute pulmonary edema. We couldn't do an exertion test for her because of the poor EF and just recovered from APO. So this is a classic example to show that when we scan, we should not only limit on lung, but we should also look at the patient's LV function, at least one view to look at the LV function and to look at IBC, to look at the fluid status. So all these three will help you to make a very accurate diagnosis. So this will be my last slide, the pitfalls and limitation. The limitation will be not available scan. I think many district hospitals may be not available or portable, or they have a very huge machine which is difficult to push around. Not trained personnel, as accuracy of finding influenced by training and experience. So that will be my advice. If you're going to scan somebody, you must have a very good basic skills of scan. You must go through some trainings, hands-on trainings. And if you're doing it for first time, it's always advisable to have someone, some experienced person to stand beside you to guide. Patchy pattern, need to scan all the chest anatomy. As I showed earlier, where one lobe will be normal, the other lobe will have a B line. So COVID-19 can have a patchy viral pneumonia pattern. So you must scan all the 12 points before make your conclusion. Follow the SOPs, infection control, as the first 2-3 slides, which I've told you the proper way to clean. And always remember that in the lung scan, some pathologies which is deep within the tissues, perihilar lesions, lung mass, malignancy can be missed. So lung is more accurate on picking up pulmonary edema, viral pneumonias, pleural effusions, ARDS, and not mass or some deep tissue lesions. Okay. So always integrate lung ultrasound with the overall clinical picture, clinical judgment, and laboratory tests. So it all comes into one to make your diagnosis and treatment. Thank you. That's all my presentation for today. I will pass the floor to Datuk Seri back, and if there's any questions from the floor.
Yes, thank you very much, Dr. Vijayan. That was an amazing presentation, and I think that was really eye-opening. It was all-encompassing. You covered various angles of lung ultrasound. Now, there are a few questions from our attendees here. The first question is probably any post-COVID investigation that can be done in the hospital or the clinic. I believe the attendee is probably asking how can we use ultrasound in the hospital or a clinic? Like, for example, I would suppose that this would be a post-COVID patient, and the patient has come back with shortness of breath a week after discharge. So because the topic for today is ultrasound, how could we use ultrasound in the clinic to come to a clinical diagnosis?
Okay, so unless you have a baseline ultrasound with the scoring, when this patient was admitted, for example, score is 16, you are discharging him on the day 14, and this patient is coming back on day 30, and when I scan him back, and the score system is double up 30 plus, that shows this patient already developed some organizing pneumonia. The lung is getting worse. Okay, but if there's no baseline scan and I'm scanning him for the first time in the clinic setting, and when I get a score of 22 or 24, I won't be able to judge, is this lung changing to organizing pneumonia or is it getting better? So again, I'll go by clinical judgment at that point. But most of my presentation and the papers are looking at the acute COVID-19. We don't have an established papers to support post-COVID clinic lung ultrasound. Yeah, so most of the presentation, my presentation is looking at the acute clinical presentation in the ED or in our wards. Of course, in a hospital like in Sydney and few hospitals in Australia, they have used this scoring system to decide patient to be admitted or to home quarantine. So they have a point system. Those who score below 12 points goes back to home and quarantine. Those who have 12 to 26 points admitted to general medical ward. Those who have more than 26 get admitted into intensive care unit. Yes, they have this point system, scoring system for decide on admissions, but not in the clinic setting.
So probably maybe what might happen is if there was a patient who presented with shortness of breath and, we're not exactly sure. Of course, if it was acute, they would be at the ED, but probably we can pick up maybe possible pneumothorax or possible consolidation. But as you mentioned correctly, Dr. Vijayan, we would need a baseline scan to see if there's a deterioration. But if there was no baseline scan, I believe a scan at the clinic will give some information, isn't it? Whether there's pulmonary edema or whether there's any consolidation or pleural effusion. Okay. The second question, Dr. Vijayan, what is the best probe to use when we are scanning the IBC?
IBC, okay. I usually use a curvilinear probe. If I have 3 probes options, yes, I will use the curvilinear probe, abdomen probe. But if you have this portable ultrasound where the probe that I showed, which have a multi-purpose, then I will put a echo mode to scan the IBC. So if you have a luxurious, you have 3 probes, curvilinear will be good. If a multiple probe, then you use an echo mode to do the IBC.
Okay, all right. The next question from Dr. Ahmad Lazwadi. the lung ultrasound score accuracy, it is highly sensitive to predict the mortality rate for mechanic. So basically, is the score accurate or sensitive when we want to predict mortality rates on mechanically ventilated COVID patients?
So the paper that I showed earlier, this is a scan which was done in ED. Okay. So when they put a 26 and above score, their percentage was 92% of their patient died who scored more than 26. And those who scored 25 and above, 90% of their patient got intubated. So this is a patient where the study was done based on the first presentation at ED. It's never been done in a patient who's been ventilated and to look for outcome of the ventilation based on these research papers. But again, if this patient is ventilated and the score is high, more than 26, yes, I will personally say the prognosis will be not good for those who have a very high score, more than 26 and ventilated.
All right. And Dr. Ahmad again. So can ultrasound replace the need for CT scanning as far as lungs are concerned to assess COVID lungs? And would this be applicable especially for Cat5 patients?
So if you are just going to look into lung fibrosis, post-COVID organizing pneumonia, yes, I can say that lung ultrasound is sensitive enough based on all these studies. But there's another arm that we might miss, pulmonary embolism or pulmonary arterial thrombosis, which we see frequently. So for that arm, a CTPA is needed to be diagnosed. But for the arm of organizing pneumonia, how bad is the lung infiltration? I think lung ultrasound is sufficient enough to continue your inpatient management. Yeah. But unless you want to rule out pulmonary embolism, you need the CTPA.
Very true. But I guess probably at the bedside, maybe, I mean, of course, to pick up pulmonary embolism would be difficult using the lung ultrasound machine unless it's massive PE. Maybe we can still pick up some right ventricular strain, some acute dilatation on the right side. But of course, it would be more useful, I think, in NS patients to make sure there's no pneumothorax, especially when you are ventilating those tough COVID patients with very high pressures. Barotrauma is such a real risk. And also when you are worried about basically consolidation setting in, isn't it, with the ground glass appearances on the lungs. So I guess the take-home message, I guess, any other questions from the panel for the attendees for today? Well, it was quite good. We had a few questions from the attendees. But I think, Dr. Vijayan, what you mentioned, could we just look over the clue protocol again? I think that was very important.
Okay.
And if there's anything that the attendees should take home today, they should, I think, take home the message of how to apply clue and the lung ultrasound scoring. That was very, very good, because this is something that all of us can use objectively. It's something that, of course, there'll be many methods. All right, just like there are many methods of scoring for pancreatitis. All right, every time you come back, there's a new scoring system. But at least this is something to take forward for our attendees. All right, something that they can all talk about basically. Okay, there's another question that just came in. Meanwhile, how do hypoxic pulmonary constriction and pulmonary embolism, how to differentiate hypoxic pulmonary constriction rather, and pulmonary embolism from RV strain dilatation?
Okay. So, RV strain is not significant for pulmonary embolism. Yes, true. Why? When there's a pulmonary embolism takes place, most of your pulmonary vessel goes into a constriction, spasm. Not only that, the pulmonary artery which has emboli, but the other normal pulmonary also goes into a spasm. That's when patient goes into a tachycardia, and it gives a very high strain on the RV. Can echo differentiate, or lung ultrasound can differentiate these two? No, I don't think so. No, you still have to go to CTPA to show these findings. And in COVID-19, it's always subsegmental pulmonary embolism, which is you won't be able to pick it up in lung ultrasound. It's still CTPA will be ideal. And recently, I think there's a guideline for us from Hospital Ampang that if you have a patient with high suspicious of subsegmental PE or pulmonary embolism in COVID-19 patient, you can empirically start DOAC, anticoagulant, and you can repeat the CTPA as an outpatient within 6 weeks of the discharge. Because like in Klang GH, we have a huge patient and our pending cases, like, few hundred patients pending for CTPA. Then we followed this guideline where we could, discharge some patient with a high risk with DOAC, and we get CTPA done as an outpatient, and we saw them in the post-COVID clinics.
Yes, that's true. Probably because they both have the same mechanism. They both will cause RV strain and adaptation. It will be difficult. Okay. So now
this is the diagram. So you can make a small chart, a small box of charts like this. And the most important is the scoring system, where again, I'll just go through. 0 if it is normal. 1 if you see 3 B lines or 4 B lines. 2 points if you see a confluent B line, you can't unable to count. And 3 when you see a consolidation, subpleural consolidation. So you just can key in, okay, I saw 1 here, I saw 2 points here, 2, 1, 0, 3. Then you make a conclusion. What's the score you get? You may get 21 score. Then after 24 or 48 hours of treatment, you can repeat back the scan. You can document back again the point system, and you can see, does the patient responding or is getting worse?
All right. I think that was a good something to take home. A final question from our attendees, from Rebecca. She says, thank you for the informative talk. Now, she wants to know what features can we use to confidently differentiate between a viral pneumonia and a bacterial pneumonia. Reason being, probably we want to decide when we need to start antibiotics for nosocomial pneumonia when a patient has been staying in a hospital for more than 48 hours. So, but I think for COVID, antibiotics always last, isn't it? Usually this, but how do we distinguish between viral and bacterial pneumonia, Dr. Vijayan?
Right. So if you look at here, this is a subpleural consolidation. I'm sharing the screen, right?
Yes.
Yeah, okay.
We're seeing a presentation actually.
True. So you can look at here and looking at here. So this part is more significant for bacterial pneumonia, where we call it as a tissue paper sign. You can see multiple air bronchogram, white spots. This is an air bronchogram. Fluid shows black color. The air bronchogram shows a white color. So this is a fully lung consolidation, which very rarely happens in COVID-19 pneumonia. But if you see these pictures, it's a subpleural consolidation, which is very significant for viral pneumonia. So these two may differentiate, number one. Number two is pleural effusion. You can see a parapneumonic effusion, where in COVID-19, it's very rare to have COVID-19 pneumonia with effusion. But we can see more bacterial parapneumonic effusion. So that will be another second point. Third is the B line, where earlier I showed you the upper lobe will be normal, the lower lobe B line can be seen. And when you get these pictures, you need to correlate again back with the clinical findings, with the EPID contact, and with other laboratory investigations. So it doesn't come just you scan and you treat the patient, no. It's going to be a package of clinical presentation, the epidemiological contact, and your scan. So this scan is just to give you an extra hand points to make your diagnosis. Yep.
All right. Thank you very much, Dr. Vijayan, for the very informative presentation. Any further questions from the attendees? like the part about the subpleural consolidation. I think the tissue paper sign, that's very useful, I'm sure, for our attendees. So in summary, I think it's very important for us to realize that ultrasound is not just the only way. It has to be used in the clinical picture. It's probably like having a tool. It's like you're in the emergency department and you have access to troponin T that you can do in the ED. It may not be the HS trop T or the high sensitivity trop T that will give you a good answer, but even if it is positive, the ED trop T, it points you in that direction. So when you do not have CT scanning facilities available, then I think ultrasound becomes a big game changer. It can be done at the bedside. It can be done immediately. And the best part about it is you can do it as often as you want. Try doing a CT scan every day for the same patient. The radiologist will be very upset with you. But I think you can use ultrasound confidently every day, and we can use the scoring system. Am I right, Dr. Vijayan? Can we use the scoring system on a daily basis?
Yeah, can.
From your experience, how frequently have you done the scoring? Do you do it twice a day? Or
okay, so I go in and do it as needed when the patient deteriorates or when we have difficulty to wean off oxygen. So that's when I'll go and scan. And if I've done a previous scan, I will compare with my previous scan and the current scan which I've done. And if that point's increasing, then I know that lung pathology is worsening. Then we need to step up our treatment. Yeah. So I will only go in scan when it needed. Like, for example, difficult weaning of oxygen, patient oxygen requirement needed worsening, and patient not responding to treatment. So that's when we do a repeated scan.
Okay. Thank you very much, Dr. Vijayan. At this point, we just before 4 o'clock, just to wrap up, at this point, we would like to thank the College of Physicians for organizing this weekly webinar. We hope that it has benefited all our physicians who have joined us today. And for the junior ones, in the last 1 minute, if you have junior physicians, me and Dr. Vijayan both are AAIM physicians, Advanced Acute Medicine. We would like you to find out about it. It is a very exciting field. It is new. And the best part about it is you decide what exactly interests you in it. So if you have an interest in OGDS, like Dr. Vijayan, you can do AIM, and you can also do scopes at the same time. If you like rheumatology, then you can do AIM and also have a rheumatology rotation. And the idea is that all of us eventually must be strong in general medicine. And AIM focuses on general medicine, and it allows you to choose the rotations that you are interested in. If there's any further information on ultrasound or advanced acute medicine, please contact us. We'll be more than happy, isn't it, Vijayan? We'll be more than happy to guide you.
Yeah, true.
We need, and it's a new specialty, we need all the numbers that we can get. Without much further ado, I would like to hand the chair back to Dr. Ang from the College of Physicians. Thank you very much for spending time with us today.
Thank you.
Thank you everyone for joining the session today. Don't forget to join us for our next week's session on management and diagnosis of respiratory sequelae in COVID-19. There won't be any QR codes for you all to scan. The College of Physicians will key in the points for you all. Thank you for joining us.